So David, thank you for doing this. David Papke is a pathologist at the Brigham and Women's Hospital, and one of his primary interests, if I'm not mistaken, David, is bone and soft tissue pathology. See, do you want to tell us a little bit about yourself and what led you to bone and soft tissue pathology?
Sure. Well, first, thank you very much for the opportunity to talk here. I really appreciate that. So, as you said, I'm a pathologist here at Brigham and Women's Hospital. I sign out GI and bone and soft tissue pathology. What drew me to soft tissue, I think in particular, is the diagnostic challenge that many of the cases presents. There's a puzzle-solving aspect to trying to get to a diagnosis, and I really enjoy that process, and it's very satisfying when you can get to a diagnosis, particularly in a case where it's not that obvious when you first look at the H&E.
Yeah, yeah, no, no. I'm not going to try and put the other services under the bus, but bone and soft tissue pathology is probably one of the most challenging services, and certainly something that certainly led me to bone and soft tissue pathology as well.
Yeah, I was going to say that must have been one of the reasons why you went into it as well.
Yeah,
I
yeah,
hope
and
so.
you're at a great place with some superb, perhaps the most expertise on bone and soft tissue pathology that I know of in the world. So it's a great place to work in.
I'm very lucky to have had good mentors here, that's for
Yeah.
sure.
All right. So what we were planning to do is to just discuss a few cases, and so I'll let you talk through them. And these are a couple of new entities that some of which David has had a major role in describing. And so, do you want to take it from here?
Sure. I'll go ahead and share my screen. All right, yeah, so I'll just present a few cases here, and these are all tumor types I'll mention that I recently wrote about. Vikram had asked me to write a review article discussing some emerging entities, and I was lucky to have a talented trainee at our institution, Emily Towery, who kindly agreed to do this with me. So these tumor types we'll discuss in a lot more detail in that article. If it's something that you're interested in, I'd encourage you to read this article. So the first tumor here, this is a foot mass in a 48-year-old male. You can see that this tumor is growing through the dermis and the subcutis. It's a spindle-cell neoplasm. On higher power, you can see that it has significant nuclear pleomorphism, but there's a paucity of mitotic activity. Actually, if you were to look around this tumor, it would be difficult to find any mitoses at all.
I would have guessed that this is just a UPS.
Well, it's funny you mentioned that because in the old days, that's what they were diagnosed as, is low-grade UPS. But now we know a little bit better. So these tumors, just to point out a few of the features that are diagnostically helpful, you can see that there's lipidized cytoplasm. There are these bizarre and large nuclei, some of which have nuclear pseudo-inclusions. And some of the cells have glassy eosinophilic cytoplasm. Also, if we look around the tumor, you'll see that there are areas with these prominent foamy histiocytes, which is another useful diagnostic clue. So this tumor is diffusely positive for CD34. It expresses keratins. This is a pitfall for the misdiagnosis of sarcomatoid carcinoma, although the lack of mitotic activity should give you pause in that regard. It also expressed desmin, which can happen in some of these tumors. And it's diffusely positive for CAD-M3. This is a cell adhesion molecule that's expressed by this tumor type. It's a specific and sensitive marker. So this is a superficial CD34 positive fibroblastic tumor. This is a tumor type that was described for the first time in 2014. I would say now I think it's gained wide acceptance as a distinctive tumor type. These occur in the skin and subcutis. About 3/4 of cases occur in the lower extremity. These can very rarely give rise to regional lymph node metastases, but the patients who develop those metastases don't seem to develop any additional metastatic disease, and so far there are no patients to date who develop distant metastatic disease. So these tumors can behave in a slightly locally aggressive fashion, but generally speaking they're pretty indolent. And in fact, most of them don't locally recur after resection. So despite their really pleomorphic and sometimes striking appearance, they actually behave in a relatively indolent fashion. We now know about the genetics, which we discuss in this article. I don't want to go into too much detail here, but the take-home is that because of some of the genetics of these tumors, they overexpress the cell adhesion molecule in 95% of cases. And this is actually a specific marker for this tumor type. So this is something we're using routinely now at Brigham.
Oh, that's terrific, David. So just two questions. One is, what is the one feature that what's the tip-off that you're dealing with this tumor and not a UPS? And
Oh, sure. Yeah, well, for me, it's a combination of superficial location, nuclear pleomorphism, and paucity of mitotic activity.
okay,
Those three things combined really are pretty specific for this tumor type. The glassy cytoplasm is also another very useful diagnostic clue.
And is it the function? I mean, we know that dermal and subcutaneous sarcomas tend to do better. So is it a function of location or is it a function of biology, the good behavior?
That's a very good question, and I think there probably is not a very good answer to that question right now. These tumors can primarily occur in subcutaneous tissue as well. That's uncommon, but it can happen. So they're not all confined to the dermis. Many of the dermal tumors do invade subcutis as well. As you know, for other tumor types like smooth muscle neoplasms of the skin, if they show nuclear atypia and they invade subcutaneous tissue, then they acquire metastatic potential.
Right.
That is not the case for these superficial CD34 positive tumors. So yeah, it's a very good question without a very good answer at this point, I would say. Okay, so case 2. This is a paraspinal mass in a 49-year-old male. You can appreciate at low power that there's this vaguely lobular growth. It's pretty monomorphic. I'll show you one high power field. Basically, the whole tumor looks the same at high power.
Can I just say that I would call this endocrine tumor, and endocrine tumor.
Yes.
And I would throw a synaptophysin and chromogranin at it and then repeat it because it's negative. So.
Yeah, that's exactly, I'm glad to hear you say that because we thought they looked a lot like well-differentiated neuroendocrine tumors, which is how we name the tumor sort of in a way. But anyway, so this tumor is extremely monomorphic. Like a well-differentiated neuroendocrine tumor, it shows monomorphic round nuclei with speckled chromatin. The cells are epithelioid with pale eosinophilic cytoplasm. They're growing in these nests and trabeculi, so it looks very much like a well-differentiated neuroendocrine tumor. But you throw your keratins on it, they're negative, which of course for a well-differentiated neuroendocrine tumor, that's almost unheard of. That's very, very unusual.
Right.
Neuroendocrine markers are negative, so INSM1, synaptophysin, chromogranin are all negative. I will mention, we don't use CD56 here, but I have heard from outside pathologists that CD56 can be positive in this tumor type, so that is a potential pitfall if you're using that marker. But the useful marker in this tumor type, as it turns out, is beta-catenin. You can see that it's diffusely positive in the nucleus. So, as Vikram alluded to, these tumors look very endocrine, which is why we named this tumor type pseudoendocrine sarcoma. So this is a tumor type that we described about a year ago now. And these tumors tend to occur in older adults. The median age is just over 60 years. And they have a striking predilection for paravertebral soft tissue. Almost all the cases occur in paravertebral soft tissue, often with secondary involvement of vertebral bones. These are locally destructive tumors. So with clinical follow-up, we've learned that these, despite their really bland appearance, they're actually sarcomas. They're locally aggressive. About 40% recur locally, and as I mentioned, they can be destructive local recurrences. And about 20% of patients in our series develop lung metastases. So these tumors have metastatic potential. And so that's why we called them pseudoendocrine sarcoma. Just to show a few other images of these tumors, because they look very distinctive once you've seen a few. They show this extremely monomorphic growth, in a way even more monomorphic than you'd see in a typical well-differentiated neuroendocrine
Right,
tumor.
it's a little too perfect.
A little too perfect, exactly, yeah. And you can see this tumor is growing in trabeculi and nests. The salt and pepper chromatin is there, just like a well-differentiated neuroendocrine tumor. Some features that you can see, about 2/3 of these tumors show pseudoglandular architecture, where you get these spaces that are lined by tumor cells, mimicking glands. About half of tumors show these extracellular hyaline globules that we see here. It's another useful diagnostic clue. And about 1/3 of cases show pseudomonas calcifications, which can be quite prominent in some cases. So as you'd guess by the IHC, these tumors harbor beta-catenin gene alterations. in all the cases that we sequenced, and we basically didn't find any other recurrent alterations.
Interesting.
The take-home with pseudoendocrine sarcoma is, you have a tumor that's occurring in paravertebral soft tissue that looks like a well-differentiated neuroendocrine tumor but isn't staining right. You should think about this tumor type.
Oh, fantastic. That's certainly will be on my radar. I do wonder if I've seen one and dismissed it as a chromogranin synaptophysin negative neuroendocrine tumor.
Yeah,
Gosh.
it's actually interesting. Once we published this study, we heard from several pathologists all around that said, oh, I saw a case, I'm sure I saw a case, and I thought it was a well-different neuroendocrine tumor, but I couldn't, force it into that category. Ended up sending out, that's what these are.
All right, let's go to the next one.
Sure.
Fantastic.
So this next case, this is a chest wall mass in a 13-year-old female. You can appreciate that it's a pleomorphic sarcoma. So pleomorphic sarcomas are pretty uncommon in kids. And this tumor shows a mixture of epithelioid and spindle cell morphology. You can see these fascicles of spindle cells and then these epithelioid cells in between. The tumor has brightly eosinophilic cytoplasm and pleomorphic hyperchromatic nuclei.
So it looks a little myogenic because of the cytoplasm.
Yes.
It almost looks a little like an EHE as well, maybe vaguely. Epithelioid hemangioendothelioma.
With the stroma, But so this tumor, like you said, it does look quite myoid. It's got this brightly eosinophilic cytoplasm. But it actually shows, in this particular case, somewhat limited desmin positivity. And, a lot of these tumors actually have limited desmin positivity. So for most rhabdomyosarcoma subtypes, that would sort of take it off the table. Most rhabdomyosarcomas have diffuse desmin expression.
Yeah.
But this rhabdomyosarcoma type actually often shows limited desmin expression. That's actually a major pitfall for just not getting to the diagnosis. So you can see here this tumor is expressing nuclear MyoD1, so it is a rhabdomyoblastic tumor. This tumor expressed keratin A1A3, which is expressed in almost all cases of this tumor type. And it also shows diffuse ELK expression, which is seen in about 3/4 of these tumors. But it does not harbor an ELK rearrangement. Instead, it harbors a rearrangement in FUS. And so this tumor is an emerging type of rhabdomyosarcoma, which is termed epithelioid and spindle cell rhabdomyosarcoma. So this tumor type was identified originally through retrospective analysis of sequencing data, where it was found that there are these rhabdomyosarcomas that harbor gene rearrangements involving EWSR1 and FUS on the one hand, and TFCP2 on the other. That's the constant partner. And these tumors behave in a very aggressive fashion. All the patients in this initial series died within 5 months of diagnosis. That's borne out on subsequent series. So here's clinical data from a subsequent series. You can see that most of these patients died of disease often within just a few months of initial diagnosis. So these are very aggressive sarcomas. They can occur across a wide age range. They can occur in both bone and soft tissue sites, but they do have a predilection for occurring in craniofacial bones. And they have a pretty even split of rearrangements in FUS and EWSR1. At Brigham, if we're suspecting the diagnosis, we'll send it to FISH for both of these genes because of this even split. And interestingly, they don't have ELK rearrangements. Some of these tumors do have internal deletions in the ELK gene, and they have very high levels of ELK overexpression based on mRNA sequencing data. In fact, there's a recent report of a patient who responded very well to ELK inhibitor therapy.
Interesting.
So this may actually present a therapeutic target for this tumor type. But anyway, so the take home with this, if you have a pleomorphic epithelioid and spindle cell sarcoma, it's got some desmin expression, you should think about throwing an A1A3, an ELK, and a MyoD1 on it, and that'll get you to the diagnosis.
So the hint sounds to me is you go down the track of a tumor with myogenic differentiation, but you just don't quite see the level of desmin expression that you're anticipating. Would that be appropriate? Yeah.
Yeah, that's exactly right. And if I'm suspecting this diagnosis, I'll run desmin and MyoD1 up front, anticipating that often the desmin will be quite limited. In fact, desmin can even be negative in this tumor type. which is obviously major.
What about for somebody, say in the developing world who has no access to fish or fusion? Would this pattern of desmin, myogenin, or MyoD1 and ALK expression be sufficient to get the diagnosis?
That's right. That is sufficient, and we have made the diagnosis based on that combination of IHC markers at our institution before. We have the luxury of having the EWSR1 and FUS fish available, and because these are so rare, we like to get that confirmation. But I think it's not strictly necessary if you have the right morphology and immunophenotype, especially the ALK, like you said, more limited desmin. And I can talk about this last tumor type. So this is case 4. This is a tongue tumor in a 1-year-old male. And you can appreciate in this low power image that it's a strikingly lobulated tumor. There are these
lobular capillary hemangioma would be, at least that low power look is very much like that, But
or I would say it's also analogous at low power to the growth pattern seen in glomus tumor and in myofibroma and myopericytoma, these lobular tumor cells, which you can see are separated by these fibrosepta, which is a common feature in this tumor type. Within the lobules, you can see that the tumor is strikingly nested. There are these nests of pretty uniform neoplastic cells. They have vesicular nuclei and small distinct nucleoli. And the nests are separated by this delicate network of capillary channels, which is very typical in this tumor type. Another common feature, which is a helpful diagnostic clue, is shown here. So this is a blood vessel, and you can see that there's a lobule of tumor cells that's bulging into the lumen of this vessel, but it's not actually lymphovascular invasion in the sense that this lobule is still surfaced by endothelium, but this is a perivascular growth pattern that's seen in this tumor type. And of course, this growth pattern is also seen in tumors in the myofibroma, myopericytoma, glomus tumor family as well. So, you could think about a hemangioma, but you'll see that CD31 highlights numerous blood vessels in the stroma, but is negative in the neoplastic cells. The neoplastic cells do express MDM2.
Oh gosh, okay. But this doesn't look like a liposoc, so I think
that's right. Yeah, this is too monomorphic, and also tongue of a 1-year-old. The clinical context wouldn't fit well with a dedifferentiated liposarcoma. And the tumor also expresses this marker, which we brought online here, GLE1. And you can see with the GLE1 stain, you can appreciate how strikingly nested this tumor is. And GLE1 is showing nuclear and cytoplasmic expression.
That's beautiful stain.
It works very well in our hands, which I'll discuss just briefly in a slide here. But so this is a tumor type that we described recently under the rubric of nested glomoid neoplasm. This is a GLE1 altered tumor type. They harbor GLE1 gene rearrangements and amplification. And I don't want to get into the whole backstory here. I think it would take too much time, but if you check out this review article we discuss, there have been reports in the literature of sarcomas harboring GLE1 gene alterations and showing a wide range of morphologic findings. So we decided to study a morphologically consistent set of tumors that have these GLE1 alterations, and we term these nested glomoid neoplasms. And these tumors actually behave in a relatively indolent fashion. So they can recur locally, often with pretty long intervals between the primary tumor and recurrence. But none of these tumors in our series metastasize. We had pretty good long-term follow-up in quite a few patients. And also, some of these tumors were present for a very long time before they were resected. Again, this isn't the behavior you'd expect from a sarcoma. None of these metastasized or behaved in a locally aggressive fashion. So these nested glomoid neoplasms show lobular architecture. The tumor lobules are separated by these irregular thick fibrous septa. And then within the lobules, they show nested growth, as you can see here. And on high power, you can see, again, they have these vesicular nuclei, these small distinct nucleoli. And actually, in a way, they also sort of resemble well-differentiated neuroendocrine tumors. They have this very nested...
more so that than actually a glomus tumor. I assume in the past, were these called glomus tumors? Or what were they classified as?
So these are mostly negative for SMA. So the immunophenotype wouldn't fit. It's interesting, the low-power architecture, that lobular architecture with bulging into vascular lumina, that looks like a glomus tumor. But then this nested growth in doesn't fit so well. Also, the tumor cells don't show distinct cell borders like you see in most
Yeah.
tumors. There are some differences, more in the higher power architecture than in the low power architecture, which is why we describe these as glomoid, but they're not actually sort of glomous.
And these are negative for chromosynapto and things like that.
That's right, although they can sometimes express keratins. That's a diagnostic pitfall for well-differentiated neuroendocrine tumor. Or if these occur in the skin, that can be a pitfall for misdiagnosing an adnexal tumor.
Because many of us have no access to GLI1 IHC, so I'm just
That's
thinking in
true.
terms of it is a very distinctive. Was there much variation in the histologic between cases, or did they all look like this?
They're relatively uniform. Some of them had clear cell features, which made them look a little different in some cases, but for the most part, they were pretty uniform. One marker that can be helpful is about a third of these express S100. They don't express SOX10 though, so if you get some S100 positivity, that can support the diagnosis. If you have access to DDIT3 fish, that actually can pick up the gene rearrangements because DDIT3 is right next to GLI1 in the genome. MDM2 fish can pick up, MDM2 is often co-amplified, which is part of why it's expressed in these tumors. So MDM2 fish can also be used to support the diagnosis. But I'll grant that this may be a hard one to diagnose with an objective marker if you're in an under sort of resourced setting where you don't have access to fish.
So one last question, David. I think you made the point that you were very clear when we're defining these tumors, you demanded a certain morphologic appearance. And that's because GLI1 is expressed in other tumors as well and genetically altered. Can you speak a little bit about GLI1 altered tumors?
Yeah, so this is an area that I'm very interested in, and we're actually actively investigating right now to try to determine histologic features that can predict malignant behavior in this class of tumors. So the first tumor type that was described as having a GLI1 alteration was so-called GLI1 altered pericytoma, and those also behaved in a benign fashion. Those were described by Christopher Fletcher and colleagues back in 2004. Then in 2018, there were these series of malignant tumors that harbored GLI1 fusions and amplification. If you look at the pictures in those series, some of those tumors are also nested, but they tend to have more mitotic activity and nuclear atypia than this set of cases that we studied in the series that I highlighted. Some of them also have different morphologic features. Some can be vesicular spindle-cell sarcomas. Some are very overtly malignant looking with lots of mitotic activity and necrosis. So right now we're working to try to understand features that can predict outcomes in this class of tumors, and I think that's an open question right now.
Great, thank you so much, David. This was this worked out so well, even beyond my expectations. So, as you were going through those cases, I was, obviously I've read your review, but I must say things don't stick in my head very often. So I was just amazed by both the pictures and just the kind of work you've been doing. So congratulations and
thank you very much.
Fantastic work.
I appreciate that. I have to say the most satisfying part of these types of projects is when you're actually first finding the cases, and then you recognize that they all look the same as one another, and then you know you find something. So
I always think the hunt is the most exciting bit.
Yeah.
And then after that, everything is sort of just
the rest of it's hard. Yeah.
Heavy lifting beyond that. So all right, David.
Well, thank you for the opportunity to
Of
present
course.
these
No,
two.
this was lovely.